Welcome back to Pre-Med Compass, your trusted guide through clinical medicine. In today's video, we are diving deep into upper GI bleeding, a common life-threatening emergency that demands rapid recognition and expert management. I am Dr. Emorike, and in this session, we will go step by step through causes, diagnosis, and management of this important emergency condition. So grab your pen and paper and let's get started. Upper gastrointestinal bleeding refers to bleeding from a source proximal to the ligament of Treace. This means it involves the esophagus, the stomach, or the duodenum. Any bleeding below the ligament of Treace is lower GI bleeding. Upper GI bleeding is a common emergency associated with significant morbidity and mortality. Bleeding can be overt, which means it's visible, such as hematemesis, melena, or hematochezia. Or it could be occult, detected only with stool testing, a fecal occult blood test, or through unexplained anemia. It can be acute or chronic, depending on the onset and duration. Acute, usually sudden onset and severe. Chronic, slow, and persistent. Importantly, if not managed promptly, upper gastrointestinal bleeding carries high morbidity and mortality, making early intervention critical. Upper GI bleeding has an incidence of about 50 to 150 cases per 100,000 adults each year. In the United States, it accounts for nearly 300,000 hospitalizations annually. It is more common in men and especially in the elderly. Upper gastrointestinal bleeding are about 4 times more frequent than lower gastrointestinal bleeding. The mortality rate overall is 5 to 10%, but rises to 15 to 30% in variceal bleeding and can be as high as 40% in elderly patients with comorbidities such as renal failure and cirrhosis. Prognosis is worse with increasing age and comorbid illness. Several risk factors increase the likelihood of upper gastrointestinal bleeding. First is age over 60, male sex, Helicobacter pylori infection, use of NSAIDs, anticoagulants, antiplatelets or steroids, heavy alcohol consumption, liver cirrhosis, chronic kidney disease, prior history of upper gastrointestinal bleeding, peptic ulcer disease, or GI malignancy, and even low socioeconomic status is a risk factor. We'll look at the exact etiology of upper gastrointestinal bleeding. This can be divided into variceal and non-variceal causes. We'll start with the variceal causes. About 10 to 30% of upper GI bleeds are variceal in origin. The most important are esophageal varices. These are dilated veins in the lower esophagus that develop due to portal hypertension, most commonly from cirrhosis. When they rupture, they cause sudden, massive, and life-threatening bleeding. We also have gastric varices, which occur in the stomach and can bleed even more severely, though they are less common. Another related condition is portal hypertensive gastropathy, where the stomach lining becomes fragile and congested from high portal pressure, leading to slow chronic bleeding rather than dramatic hemorrhage. This image illustrates dilated esophageal varices as a direct consequence of portal hypertension. Now we'll look at the non-variceal causes. The majority, about 70 to 80% of upper GI bleeds are non-variceal. The leading cause is peptic ulcer disease, responsible for 40 to 50% of cases. Other common causes include gastritis and duodenitis. These are often triggered by drugs like NSAIDs, aspirin, alcohol, and steroids. Even stress is also a culprit. We also see mallory waist tear, These are longitudinal mucosal laceration at the gastroesophageal junction and usually follow forceful vomiting or retching. They can also occur in alcoholics or after even severe coughing. Esophagitis due to reflux or infection can also present with bleeding. And lastly, malignancies of the stomach and esophagus may cause chronic insidious bleeding or occasionally massive hemorrhage. Some rare but important causes include Diagnostic lesion. This is a large abnormally persistent submucosal artery, often in the stomach, that can erode the mucosa and bleed massively without an ulcer being present. It is easily missed unless carefully looked for during endoscopy. Other causes are gastric intravascular ectasia, GAVE, also called watermelon stomach. It presents with dilated vessels in the antrum that bleed chronically. Vascular malformations such as angiodysplasia and AV malformations may also bleed intermittently. Aortoenteric fistula is rare but life-threatening cause typically occurring in patients with a prior aortic graft or aneurysm, where an abnormal connection forms between the aorta and the intestine, leading to catastrophic bleeding. Other rare causes include hemophilia, where blood enters the GI tract from the biliary tree, pancreatic tumors invading duodenum, and hereditary hemorrhagic telangiectasia, also known as Osler-Weber-Rendu syndrome. Medications such as anticoagulants and thrombolytics are also implicated. However, they cause more of systemic bleeding. They don't cause bleeding in the GI by themselves, but can greatly worsen the severity when another lesion is present. This is just a summary table of the etiology of upper GI bleeding into variceal and not variceal we've just discussed. Variceal causes such as esophageal varices, gastric varices, portal hypertensive gastropathy. Non-variceal causes, the common ones are peptic ulcer disease, gastritis, duodenitis, Mallory waist tears, esophagitis, and malignancies. The rare non-variceal causes like Dulafos lesion, gastric intravascular ectasia, angiodysplasia, AV malformations, aortoenteric fistula, hemophilia, and others. Another way to classify the causes of upper GI bleeding is by organ system. In the esophagus, varices, Mallory waist tear, esophagitis, and esophageal carcinoma. In the stomach, peptic ulcer disease, gastritis, gastric varices, gastric cancer, gastric intravascular ectasia, and Dulafos lesion. In the duodenum, duodenal ulcer, vascular malformations, pancreatic or periampullary tumors. Other causes include aortoenteric fistula and hemophilia. The slides provide a visual summary of the major causes of upper gastrointestinal bleeding by organ system. You can see esophageal causes like esophagitis, varices, Mallory waist tear. You can see causes in the stomach like carcinoma of the stomach, gastric erosions, peptic ulcer disease. You could see vascular malformations also and aortoduodenal fistula. This image serves as a quick reference to consolidate the detailed discussion we just had on the etiology of upper GI bleeding by organ system. Gastrointestinal bleeding generally could be upper gastrointestinal bleeding, which comes from a source proximal to the ligament of Treves, and lower gastrointestinal bleeding, which comes from a source distal to the ligament of Treves. If the bleeding source remains unidentified, even after routine investigations, we call it obscure bleeding. Upper GI bleeding could be classified clinically into overt, where blood is visible as hematemesis, melena, or hematochezia, or occult, where blood is hidden, only detected on stool test, the fecal cord blood test, or as unexplained anemia. We also classify it as acute or chronic, depending on the onset and duration of bleeding. In peptic ulcer disease bleeding, we use the Forrest classification. The Forrest classification is an endoscopic-based grading used to classify the severity of bleeding from peptic ulcer disease. It describes the extent of bleeding or signs of rebleeding within the ulcer, ranging from Forrest class 1, which is active bleeding, to Forrest class 2, which is signs of recent bleeding, and Forrest class 3, which there is no signs of recent bleeding. This classification is crucial for predicting the risk of rebleeding and for guiding endoscopic treatment decisions. So the Forrest class 1, which indicates active bleeding, is classified as Forrest class 1A and Forrest class 1B. 1A is the spotting bleeding. This is the highest risk, requires immediate intervention. 1B is oozing bleeding, also high risk, urgent therapy is needed here. Forrest class 2 indicates signs of recent bleeding, which is 2A, B, and C. 2A is non-bleeding visible vessel. Even without active bleeding, these vessels can rebleed at any time, so endoscopic therapy is essential. 2B is adherent clots. This clot may cover an underlying vessel, often requires removal and treatment. 2C is hematine-covered base or pigmented spot, an old healing ulcer with very low risk of rebleeding. And Forrest class 3 is a clean ulcer base. This is the lowest risk, often managed conservatively. This classification is crucial because it tells us not just what the ulcer looks like, but also how likely it is to bleed again and whether urgent endoscopic therapy is required. Now, let us talk about the clinical presentation of upper gastrointestinal bleeding. Patients may present with hematemesis, vomiting of blood. This could be bright red blood, suggestive of active bleeding, or coffee ground vomitous, which points to blood that has been partially digested in the stomach. Another common presentation is melena. This is black tarry stool caused by digested blood. In massive upper GI bleeding, patients may even pass hematochezia, fresh red blood per rectum, because the bleed is so brisk, it overwhelms digestion. So what do we mean by massive upper gastrointestinal bleeding? It is when bleeding is severe enough to cause hemodynamic instability, or when a patient loses greater than 10 to 20% of their circulating blood volume, or when they require 4 to 6 units of blood transfusion within 24 hours. In more chronic cases, patients may show symptoms of anemia, such as fatigue, shortness of breath, or pallor. On the other hand, acute hypovolemia may cause dizziness, tachycardia, hypotension, pallor, or even frank shock. Your history should always include questions about NSAID use, alcohol intake, history of cirrhosis, or past history of peptic ulcer disease. On examination, watch for stigmata of chronic liver disease like spider nevi, caput medusae, palmar erythema, splenomegaly, and others. Also watch out for signs of hemodynamic instability, such as a rapid pulse or a low blood pressure. And don't forget to check for reduced urinary output, which is an important marker for poor perfusion. So in summary, upper gastrointestinal bleeding can range from subtle anemia to life-threatening hemorrhage, and a careful history and examination are vital in guiding the urgency of intervention. When approaching a patient with upper GI bleeding, the first step is always clinical assessment. You think ABC of resuscitation, airway, breathing, and circulation. You evaluate the hemodynamic status right away because the priority at this stage is resuscitation. At the same time, you start gathering a focused history to guide further workup and management. History such as previous history of peptic ulcer disease or dyspepsia, history of drug use, NSAID, aspirin, anticoagulants or alcohol, history of liver disease or portal hypertension, are there history of weight loss or systemic symptoms which may suggest malignancy? Have there been previous upper GI bleed episodes? Are there presence of comorbidities, renal failure or malignancy? On examination, you pay attention to vital signs such as the blood pressure, the heart rate, capillary refill, oxygen saturation, urine output, and the mental status. Look for stigmata of chronic liver disease, such as ascites, spider nevi, caput medusae, splenomegaly, which suggest portal hypertension as the underlying cause. And don't skip digital rectal examination. It is essential for confirming the presence of melena. Laboratory workup should include full blood count for hemoglobin and platelets, urea and electrolytes. Note that urea often rises in upper GI bleeding because of digested blood. Liver function tests to check for hepatic involvement. Assess coagulation profile for PT, prothrombin time, INRO, and PTTK. And of course, always send a blood group and cross-match in case transfusion is needed. The gold standard investigation is upper gastrointestinal endoscopy. This is both diagnostic and therapeutic, allowing you to visualize the source of bleeding and intervene. Additional imaging such as CT angiography or ultrasound may help when fistula are suspected, such as L2 enteric fistula. For obscure bleeding, nuclear scans can be very useful. Let us talk about the risk stratification in upper GI bleeding. We will commence with the Glasgow-Blatchford score. The Glasgow-Blatchford score is a pre-endoscopy scoring system to stratify risk. It predicts which patients are likely to need urgent interventions, such as transfusion, endoscopy, or surgery. A score of 0 means the patient is very low risk and may even be managed as an outpatient. A score of 1 or more signals increasing risk of intervention and the need for hospital admission. A score of 6 or above indicates high risk, requiring urgent endoscopy or even ICU level of care. This is the Glasgow-Blatchford scoring system in detail. Points are assigned based on hemoglobin, blood urea, systolic blood pressure, heart rates, and the presence of melena, syncope, liver disease, or heart failure. It is important to familiarize yourself with the score because it directly guides the urgency of intervention. The interpretation of the scores is as previously discussed. Next is the Rockall score. The Rockall score combines clinical and endoscopic findings to predict rebleeding and mortality. The scores of 0 to 2 indicates low risk of rebleeding or mortality. Scores of 3 to 4 suggest moderate risk, and a score of 5 and above means high risk with a significant likelihood of complications, and these patients may require ICU care. This table breaks down the Rockall scoring system. It incorporates clinical factors and endoscopic factors. Clinical factors include age, shock status, and the comorbidities. Endoscopic factors include the diagnosis or the source of bleeding and the stigmata of recent bleeding. The scores range from 0 to 3. By adding these scores together, we can more accurately predict outcomes and tailor management to the patient's risk level. The scores interpretation is as previously discussed. Scores of 0 to 2 indicates low risk of rebleeding and mortality. Scores of 3 to 4 suggest moderate risk, and scores of 5 and above means high risk. This table just summarizes that with increasing scores, you have increasing risk of rebleeding and mortality, as you can see from the table. A score of 0 has a risk of rebleeding of 4.9% and mortality of 0. Score of 3, rebleeding risk of 11.2% and a mortality of 2.9%. A score of 5, rebleeding risk of 24.1 and mortality of 10.38%. Finally, we'll talk about the AIMS65 score, AIMS65. This score is another widely used tool. It predicts in-hospital mortality in patients with upper gastrointestinal bleeding. The name itself is the mnemonic. A for albumin, less than 3 grams per deciliters. I for INR, above 1.5. M for altered marital status. S for systolic blood pressure under 90 millimeters of mercury. And 65 for age, over 65. Each factor scores 1 point, and the higher the total, the worse the prognosis. The management of upper GI bleeding begins with resuscitation. This is the first and most critical step. You start by assessing the airway, breathing, and circulation. You protect the airway and provide high-flow oxygen immediately. Keep the patient kneel by mouth. Then insert 2 large bore IV cannulas and send blood for relevant investigations. Start rapid intravenous crystalloid, but avoid normal saline in patients with cirrhosis. Commence blood transfusion if hemoglobin falls below 7 grams per deciliters, or 8 to 9 grams per deciliters if there is an underlying cardiac disease. In cases of shock and ongoing bleeding, early transfusion can be very life-saving. Insert a urinary catheter to monitor hourly urine outputs and track vital signs and central venous pressure at least hourly until the patient stabilizes. Before endoscopy, medical therapy helps to stabilize the patient and improve outcome. So you start patients with IV proton pump inhibitors such as omeprazole, 80 milligrams, bolus followed by continuous infusion to reduce gastric acid and promote clot stability. A prokinetic like erythromycin may be given to improve gastric emptying and visualization during endoscopy. For suspected variceal bleeding, start octreotide or telepressin infusions. An alternative is vasopressin with nitroglycerin. All patients with cirrhosis should receive broad-spectrum antibiotics to prevent infection. Correct coagulopathy as needed using vitamin K, fresh frozen plasma, or platelet transfusions, especially in severe bleeding. This early medical therapy bridges the patient safely to definitive endoscopic interventions. Endoscopic therapy. Endoscopy is the cornerstone of definitive management of upper GI bleeding and should ideally be performed within 24 hours or within 12 hours for variceal bleeding. For non-variceal bleeding such as peptic ulcer disease, Endoscopic therapy include injection therapy with epinephrine, thermocoagulation using heater probe or argon plasma coagulation (APC), mechanical therapy including hemoclip. For variceal bleeding, endoscopic band ligation is preferred. Alternatives include sclerotherapy or stenting. Balloon tamponade using a Sengstaken Blakemore tube or the Minnesota tube serves as a temporary rescue measure. Additional adjuncts include cyanoacrylates for gastric varices, hemospray, and over-the-scope clips. This image references shows an arterial active spotting from gastric ulcer indicated in image A. That is the bleeding from the gastric ulcer, it's spotting. Image B, indicated by the white arrow, shows a visible vessel, while image C shows the placement of endoscopic clips, as you can see, illustrating the precision required for hemostasis. These are tubes used in balloon tamponade. This is the Sengstaken Blakemore tube with the esophageal balloon and the stomach balloon, the gastric balloon. This is the Minnesota tube. The basic difference between the Minnesota tube and the Sengstaken Blakemore tube is the number of ports. While the Minnesota tube has 4 ports, as you can see, the Sengstaken Blakemore tube has 3 ports. This other illustration shows the placement of the tube in the esophagus and the stomach. This red indicates the esophageal balloon, and this yellow indicates the gastric balloon. When endoscopic therapy fails or the lesion is inaccessible, turn to radiological or surgical interventions. Radiological interventions include angiographic embolization of the bleeding vessels, transjugular intrahepatic portosystemic shunt TIPS, especially in refractory variceal bleeding. Surgical options are reserved for selected cases, and these include oversewing bleeding ulcers, vagotomy with antrectomy, and other surgical options as may be indicated. These interventions are life-saving when endoscopic therapy alone is insufficient. Once the patient is stabilized, attention shifts to secondary prevention. The goal here is to eradicate the underlying cause and prevent rebleeding. This sets the stage for long-term recovery and improved survival. For non-variceal bleeding, as in peptic ulcer disease, Helicobacter pylori eradication is critical. Long-term PPI use if the patient is on NSAIDs. Avoid NSAIDs or you co-prescribe it with a PPI. For variceal bleeding, non-selective beta blockers like propranolol or carvedilol are indicated. Propranolol is used for variceal bleeding because it reduces the risk of bleeding by lowering the portal pressure. Repeat endoscopic variceal ligation, that is the band ligation, until eradication of the varices. Transjugular intrahepatic portosystemic shunts for recurrent bleeding. Endoscopic therapy achieves hemostasis in up to 80% of cases, but 10 to 20% may rebleed. Rebleeding can increase mortality to 40%. Watch out for red flags which are evidence of rebleeding: rising pulse, falling blood pressure, increasing urea, fresh hematemesis, or melena. Poor prognostic factors in upper gastrointestinal bleeding include age over 60 years, severe comorbidities, ongoing bleeding, hypotension, need for greater than 6 units of blood, inpatient bleeds, rebleeding, and coagulopathy. Scoring systems such as the Glasgow-Blatchford, the Rockall, and the AIMS65 guide triage, intervention, and prognosis. Early recognition and risk stratification saves lives. Complications of upper gastrointestinal bleeding include rebleeding, aspiration pneumonia, hypovolemic shock, and multi-organ failure. Deaths may occur in severe cases. Long-term complications may also arise from repeated transfusions or invasive interventions. Prevention and long-term care. Prevention is key. For non-variceal bleeding, eradicate Helicobacter pylori, maintain long-term proton pump inhibitor therapy if NSAIDs or anticoagulants are required. Avoid unnecessary NSAID use. For variceal bleeding, use non-selective beta blockers like propranolol or carvedilol. Repeat variceal ligation until varices are eradicated. Consider transjugular intrahepatic portosystemic shunt tips for refractory cases. Lifestyle advice like limiting alcohol, avoid unnecessary medications, and adopt measures that protect your gastrointestinal health. To wrap up this lecture, let's take a look at some highlights. Upper gastrointestinal bleeding is a common and serious medical emergency. Most cases are non-variceal, with peptic ulcer disease as the leading cause. Diagnosis relies on clinical assessment, risk stratification, and endoscopy. Management includes resuscitation, medical therapy, early endoscopy, and sometimes radiological or surgical intervention. Prevention strategies are tailored to the underlying etiology. Understanding these principles can dramatically improve patient outcomes. Thank you for joining me for this lecture on upper gastrointestinal bleeding. If you found this video helpful, like, subscribe, and share with your colleagues. Don't forget to hit the notification bell so you never miss an update. Do you have any questions or insights? Drop them in the comments below. I would love to hear from you. Stay tuned for more concise, high-yield medical tutorials. This is CLIMED Compass, guiding you on your path to medical excellence.